And you are the first person to address me as Dr. Martin, so I really do appreciate that. It's quite a privilege. I'm going to be sharing my screen with everybody so you can see what exactly I'm presenting, and I hope this works. But hopefully everyone can see my screen here. And today I'll be presenting stigma linked to suicide. And the idea is, just as Dr. Amsel said, I'll be talking about developing strategies for reducing stigma around ECT. And yeah, so I'm a Guyanese American. My family, my dad's side of my family is from Charlestown, in Georgetown, and I've been back a number of times, a little bit less since COVID has happened, but I really love the country so much, and I wish I could be there now, but I'm so glad that I'm here virtually, representing Guyana, representing America, and representing the blending of those two cultures. So thank you so much for having me. And with that, we'll get started. And thank you, Dr. Hanna and Dr. Kreider, who have helped me for this project tremendously. So we'll jump right into it. So what I want to do and what I love to do is kind of orient before I get into kind of the meat and potatoes of any presentation. And so what that means is I want to give you a little bit of a table of contents. We'll start today with just the introduction, as we did, and we'll go to a little bit about what ECT is, what maybe some of the things we fear about it are, and then some of the things that we know about it, some of the things that we thought that maybe we didn't understand, or we're starting to understand more about. And we'll end off with more about how does this specifically apply to Guyana, and how can we help reduce stigma in Guyana, and quite frankly, in other places across the planet, because it's not just Guyana, and it's not only Guyana that has kind of preconceived notions about what ECT is. In fact, those thoughts are very pervasive across the United States, across Europe, across other parts of South America, and it really does prevent ECT from doing as good a job as it can for a lot of people who are in need. So this is not just about Guyana, but I'm especially interested in Guyana, and I think Guyana is a great place to have the system here and help the people here. So without further ado, let's get started. So what is ECT? Well, the first thing is the modern treatment. It's not medieval. As mentioned, it is modern, and it was developed in 1938, but since then there's been a lot of different innovations to it. The idea, in brief, is you pass a small amount of energy through the scalp and you induce this controlled synchronous electrical energy in the brain. People call it a brief seizure sometimes, but you can just describe it in different ways. Its indications, which will be talked about later, are for depression, mania, psychosis, and often catatonia, which will also be described in the future ECT sessions that will happen after my presentation. And it has a long history. It's, like I said, since 1938, but lots of developments that we'll talk about more in terms of how they started with it, how it was used in different countries, and what they did with this procedure to help people and sometimes to hurt people, and how we've moved forward from that. And it's happened across both in the Americas, in Europe, abroad, everywhere. And the big thing I want to talk about here is that stigma is not just something that we talk about in terms of something that leads to a prejudice and kind of makes people feel icky. In this kind of situation, stigma is something that can really prevent treatment. The longer things like catatonia or depression last, the more complicated it can get, and the more risk of worse kind of things happening after that. And so ECT, which is really, really a great treatment, can help break those spells earlier and with a great success rate. And that's something we really look forward to and really would love to have operating at top efficiency in Guyana and in the US. And its effectiveness is really, really great for treatment-resistant illness, treatment-resistant depression, treatment-resistant schizophrenia. It has a great reputation for these kind of conditions, though it can be used for things first line. So that's also a really great background on it. That's just a little kind of primer on what ECT is. We get into a little more of it later. So I have a little exercise here. And if you can, what I'd love for you to do is, either if you have your technology devices or your phones, if you text that number to text Alexander Mar 023 to that number. Or if you go to polev.com, type in that code, and then just tell me, type in, when you hear ECT or electroconvulsive therapy, which is what it stands for, what comes to mind? And I'll give you, I'll give about a minute and a half, just to kind of get people to throw their answers in the chat if they can. And this is really just first words that come to mind, things that you think about when you hear the word. It doesn't have to be full sentences. In fact, I'd rather just short kind of blurbs. And again, just what you think. You can do it once, you can do it twice, as multiple things come to mind.
Dr. Martin, this is Dr. Hannah. We can't see the code.
You can't see the code? Okay, so let me, can you see the screen that says, when you hear ECT, what comes to mind?
Yeah, we see the screen, but there's no number.
There's no number. Okay, so I will put it in the chat so maybe someone can read it, but you're going to text Alexander. Hold on 1 second. Make sure this works for you. All right. Alexander, M-A-R, O23, and you're going to text that phrase to 37607. And it's just a technology bleep. So if it doesn't work in about a minute, that's fine, we'll move on. But I just want to kind of give it a chance, be a little interactive since I'm not there with you, which I really wish I could be. But we'll give another 30 seconds, see what happens. And if nothing, we'll move on. And again, that's Alexander, Alexander, MAR 023, and you text that to 37607. Or if you're on the web internet, you can go to polev.com and enter Alexander, MAR 023, and then it'll send you the activity right there. Give another 20 seconds, and then we'll move on.
So Alexander, just as an example, if you see, I have entered an example just to know that you should see at least one.
All right. Yes, I see 2 coming in. So good. So, just we'll move forward from here, but let's go to the response and see what we have here. So, oops, gone too far. All right. So shocks and scary. And those are 2 words that do come to mind quite often. I'm not sure if you can see that, but shocks and scary, 2 words that come to mind. And, oftentimes you do this exercise and the internet or the system is working, you get a lot of answers like this: scary, uncertain, shocks, electricity, brainwashing, things like that. These are common answers you get coming to mind. I won't spend too much more time on that. So what I want to do now is give you a little bit of a timeline of ECT from kind of when it started to kind of its implementation in Guyana and where we hope to go from here. And the first way, the first bit of history we can give you is that this scientist, his name was Meduna, he noticed that in certain brains, there was this high number of these immune cells, microglia. And he said, well, I find that in a certain condition, there's this high number of microglia, and in another condition, there's a low number. So I wonder if I can use both of them and kind of counteract each other. And he found that he wanted to do this with basically catatonic patients and see if he could induce some kind of seizure, because the seizure patients had this high number of these microglia immune cells, and these catatonic patients had a low number. And so he injected camphor or basically a type of medicine into these patients, and they had this seizure. And he found that actually after a couple of injections over time, these patients woke up from their catatonia and actually significantly improved where they weren't improving before. And that was the first kind of idea and theory behind ECT. This Italian team in 1938 later said that, the part of injecting camphor into somebody, what it did was people had this sort of waiting period where they wasn't sure when they were going to have a seizure, and they got very fearful and had a lot of terror. And so they said instead of doing that, they could control for when this happened a little bit more by using alternating current and kind of giving people a little bit of that current on their head for 0.2 seconds. And it would help to treat psychosis. And they used it first in a 39-year-old man. And after about 4 to 6 sessions, they started to see improvement where he was no longer as psychotic as he was. And as things continued, he improved over time. Now, in 1944, 1952, they said, these guys, Bini and Cercletti, did a great job in developing these technologies, and as did Meduna. But people were concerned because people were getting injured when you have a seizure. Sometimes your muscles were moving quite a bit. And sometimes people were biting their tongue. And they wanted to see if they could change some of these things to help improve these things. Holmberg and Thesleff decided to use succinylcholine. What that is, the muscle relaxant. It helps relax the muscles. And there's a bit of a history behind that involving Guyana we'll talk about later. But indeed, and also Lieberman in 44 decided that he could actually decrease the amount of time you're exposed to electricity, and you would still get the same benefits and reduce the side effects. So sometime between 1970 and 1984, 85, Guyana actually implemented ECT, as did many other countries in South America and many other countries in North America and Europe. And it was in the old New Amsterdam Hospital in Berbice. I think they used to call it the Madhouse, from what I remember, the Berbice Madhouse. But we use different terminology now. That's what it was referred to as. And the usage wasn't really clear. We're not really sure what was given there and how long it was in use. But that's when it started. And at some point after 85, it was discontinued. In 2015, they reintroduced an ECT machine in Guyana, donated from Canadian team, and they used it to treat about 45 plus patients who really did improve some bipolar patients. We can talk about them later and see how they did improve and understand a little bit more about that. And we'll get into that a little bit more too, but I just wanted to give you a timeline of what happened. And the next thing I want to talk about is kind of moving on that graph of that table of contents. What do we fear? So we understand what it is, but what are we concerned about here? Some things that come up often when you say electroconvulsive therapy are brainwashing or mind control or mind wiping or mind erasing or even torture. Or in certain cases, there were even government-sponsored kind of experiments with them. Something big that happened that was talked about a lot was something called MK Ultra, which was a project by the CIA to kind of do some kind of brainwashing experiment where they injected people with LSD or a drug, a hallucinogenic drug, and then put them in ECT chairs and tried to see if they could induce new memories. It failed. It didn't work like that, and it doesn't work like that. But it's something they tried, contributed to this poor history and this kind of dark history of ECT that it kind of gained a bad reputation for and is hopefully moved on from now. But more than that, there are still some risks that people are concerned about, even in the modern day times. And those risks can be split into physical and mental risks. So one of the main physical risks that people discuss a lot is this risk of injury, because when you see it on the TV or in the movies, One Flew Over the Cuckoo's Nest, other movies you may have seen, you see people often shaking and convulsing, and that's very scary. And it's primed a lot of questions about how do we reduce that risk? How do we make sure it doesn't happen? And studies were done that showed that if you don't give certain medications, you can have things like shoulder dislocations and injuries from people tongue biting, from people shaking. And so one of the innovations that was done back in the 40s and is still continues to this day with new medications is giving both a muscle relaxant to make sure no one's really shaking that often and anesthesia to make the experience more comfortable for patients who sometimes feel terror when they're they feel like maybe their chest is tight or they're not breathing well, we really give them these anesthesias to make them more comfortable, because it is quite safe. And as a result, you actually don't get much physical injury at all. Maybe a toe will shake, maybe a finger will shake, but you don't see much more than that. And so that was a really excellent innovation that came about as a result of some of these studies and these questions that people asked. One of the interesting things about this is that Guyana actually played a big role in developing the muscle relaxant piece. There was a man named Bennett who decided, when he looked over some writings that some American scientists saw in Guyana, they said the Makusi tribe noticed that they were using these kind of poison-tipped arrows on animals, and when they shot the animals in the Amazon, in Guyana, Venezuela border, the animals would freeze and paralyze, it wouldn't die. And he said he wondered what that was, and he found that it was curare, one of the medicines that was kind of isolated in South America, right in Guyana. And he took it back and he tried to use it as a muscle relaxant. And in fact, it worked. It did help relax the muscles, and patients were not harmed by that kind of convulsing that you would get before this. Eventually, that was refined, that curare was refined into the things that we use now, succinylcholine, a common drug that we use. But Guyana was actually instrumental in kind of adding this muscle relaxant portion to ECT and making it safer. So I think it's a really fun fact, a really interesting fact, and something that we see often as, I think I see often as a Guyanese American, is that people come and they see things in the rainforest, they see things in the environment that Amerindian tribes used as a daily way of life, and use that in science that we don't necessarily hear Guyana's name in, but we do use every day. So it was very interesting. Like I said, curare was turned to succinylcholine, and we got great muscle relaxants. We also use anesthesia to make the procedure easy and comfortable. And those are really the key takeaways here. We call it modified ECT as compared to unmodified, which is the ones that you see on TV and the media where people are shaking and getting hurt. The other risk that we talk about are some of the mental risks. Some of the things that you also see on TV are these things about mind wiping or brainwashing, or people forgetting everything that happened to them and new memories inserted. Now, some of those can actually happen. We can insert new memories as much as we want to. Governments can't do that. We can't do that. I can't do that. No one can do that. But one of the things that people were concerned about is that depending on the duration of the electrodes and where they were placed, after the procedure, you may have a certain period of time where the patient would have some amount of memory loss for maybe the couple hours before the procedure happened. And that was concerning for some people. So a lot of research went into what we do to make this better. And in fact, they found that certain positions of the electrodes on the head and reducing the time that you're exposed to electricity can reduce that memory loss. So maybe you'll lose maybe the hour what you ate for breakfast before you had the treatment, or maybe you won't lose much at all. It really depends on the person, this individual, but it's short and it's not for anything longer than a couple hours, or maybe, the day before you had the treatment, and it doesn't last forward. It's not going forward until you're grading. Oftentimes they did a lot of research experiments on understanding how you could talk to people and how you could give them coaching and guidance as to what they would experience. And that reduced a lot of the fear for both the patients and the families who were getting this, who were watching their kids, loved ones get this treatment. And it really did help them understand more and help reduce the stigma in a lot of these different cases. And these studies were done both in the US and Europe and Iran, all different places. And we saw the same effects there, where there was guidance given and good counseling. There was a reduction in the stigma, and people felt more comfortable doing the procedure. So right now I have a video for you of a patient that we had actually over here in Queens, New York, Zucker Hillside Hospital, who is undergoing and underwent ECT treatments. And I'm just going to play the video for you. It's a short clip, about 2 minutes, and she'll tell you a little bit about her experience, and you can hopefully this will play and you'll be able to hear it well. Please let me know if you can't hear anything.
I learned about ECT because I had hit a point where I was at the end of my rope in terms of treatments. I started in February of 2015, and the reason I can remember the month and the year so well is that was the latest and last suicide attempt I had. The results have been literally life-changing. There were fewer ups and downs, and then when the ups and downs would hit, the ups weren't as high, the downs weren't as low. So it felt like my world started leveling out.
There are many patients that can benefit from ECT. Patients who basically have a mental illness that is not helped by medications or psychotherapy, and it's severe enough to disrupt their lives.
I come every 4 weeks, and it works wonderfully.
We induce a seizure by stimulating the brain with the electrical stimulus. It's like rebooting the computer. It's not going to change the capacity of the computer. It's not going to change the hardware, but it's going to, let's say, debug the software and let it work the way it should.
The actual process and procedure is painless, is simple, is easy, and is not scary.
In many movies, it's portrayed as a form of punishment, which is far from the truth.
I'm in my sweatpants and comfortable shirt, and they run an IV, and the doctor gives you some medicine. I go to sleep.
The patient does not feel anything. The seizure lasts for maybe 30, 40, 60 seconds. The anesthesia by itself lasts for about 5 minutes, making it one of the shortest procedures in medicine in general.
It's made a drastic change in terms of what I can do now, in that my relationships with my husband, with my parents, it was so hard for them to go through all of these things, standing there, and a lot of times feeling helpless. Now I can have so much more to my relationship with them because I can interact on a much more stable level, and I can interact with them on a much more even keel. I have so much more happiness in my life than before. Not only
Just wanted to share that clip with you and give you a sense of what she was experiencing. She really had, a comfortable experience, and we're so happy that she's feeling better. And just kind of share that with you, because we don't often get to talk to patients who have experienced this, partially because of that stigma, but partially because we don't know it works so well. We don't know necessarily that they may have gone through this treatment. If they're functioning in society and they're looking as if, like you or I, you may not even know that they've been going through these treatments and going and feeling better. And that's really what we love to see. And it's really one of the great benefits of ECT. So what we do know now is that this procedure is safe, it's effective, and it's something that we really love to use because it works. It's very fast, and it's very good for patients. The key things here are that there's no brain damage, and this is not an electrocution. It's a very, very short and small amount of energy. And like you saw in the video, the most you get is maybe that little toe twitch or something like that. And we actually saw that in some studies, in a lot of studies, you get an increase in the brain volume in depressed patients after using it. And that we don't understand exactly what's going on there, but we do see the increase in parts of the brain related to memory, and parts of the brain related to how people, where it's usually shrink in depression, the hippocampus. And so that's really a nice benefit that we see. And there are changes in your heart rate that are common, but they're transient. They really don't last very long. And we can always manage them with medications. They last maybe a couple seconds, a couple minutes. It's effective. You can see improvement as early as 4 sessions. Usually people go anywhere from 2 to 3 times a week. And you can see improvement, as early as even 2 weeks or 3 weeks, and sometimes even 7 weeks or so. And you really get improvement, significant improvement in many, many patients in that kind of thing. After those number of treatments, go on a maintenance regimen, maybe once a month or twice a month for a couple of months, and you may get weaned off of it, and that may be it for you, or maybe there'll be a couple more maintenance treatments. But oftentimes you do see a remission, and that remission is very long lasting. And like I said, it's easy to use in terms of you can really go through many, many patients in a day. The procedure is very short. And anesthesia, like you said, is about 5 minutes, and door to door is about 20 minutes. So you can really treat a lot of patients with this who are having problems and help them with their depression, help them with their catatonia, help them with some of the symptoms they're experiencing, whether it's schizophrenia or a manic episode of bipolar disorder. So last piece of this is its kind of usage in Guyana. And like I mentioned or alluded to, it's already kind of seen use. And we saw some Starbuck news in 2015, but there was a couple patients, and this patient in particular this was written about, was profiled, and he had been living with bipolar disorder for about 11 to 12 years, relatively young, but he was struggling. He was struggling to keep his job, struggling to work, and struggling to be successful, and struggling to study because he was studying as well. And he felt like none of the medications were working. It wasn't helpful. And you see this sometimes where sometimes people are treatment resistant and the medications are not working. And in 2015, when the Canadian team brought over the ECT machine, they really did treat a good number of patients, and he was one of them. And over time, over the course of a couple of months, he improved to the point where he felt like he was good studying. He was studying a lot more. He felt more comfortable, and he felt like he was able to hold his own and be a normal part of function with his family and friends. And he really didn't feel different. And he really did see that there was an improvement here. And we were very proud of, I'm sure everyone was very proud of him. And it's really great news that this happened. 45 at least other patients were treated. So that was also great news. And they also got, hopefully, very good results. One of the reasons this is so important in Guyana, though, especially, is that the rate of suicide in Guyana is actually quite high. And when I say quite high, I mean arguably the second highest in the world, according to the WHO. So you can see here we have that green line, which is the Americas for both genders. That yellow line is the global average for both. And that orange dotted line at the top is Guyana men. And that blue line, of course, in the middle is Guyana both sexes. So Guyana is far above the global average, the Americas average. And it's really seemingly a big problem in Guyana's men, a massive suicide rate. And a lot of that can be traced back to depression or other mental illnesses that can be helped with ECT, with prompt ECT and prompt treatment. And so getting it in Guyana is a very big concern, not just because it's a good treatment, but because Guyana needs treatments to help this population of people. So one of the things you struggle with, of course, is making sure people actually want to use this, because we can't force this on anybody. This is not, a medieval times video. We can't force this on anybody. People have to willingly say, I would like to accept this treatment. To get there, you really have to get rid of the stigma that says, I'm scared of this treatment. And it's a very complex task, and it's not easily done because there's been many years of media and programming saying that this was a scary, scary treatment. It's very compelling in the movies to see someone getting hurt by this, or the government using it for evil, nefarious purposes, like some kind of villainous thing. But that's not really the case. And to combat that, there are some steps that we can take to mitigate the stigma and reduce it so people can take advantage of it more often. The first step is direct and purposeful counseling. The next step is, surprisingly enough, de-emphasizing some of the neurobiology, the reasons for depression, being more open about the procedure, and sharing narratives of improved functionality like you saw in that video that we shared. And the third, more long-term task is giving counter media campaigns that help explain the procedure, how we use it, how we benefit, and movies, maybe movies, videos, shows that show it being used in a good light as opposed to this negative light. And also having experts who can talk about this procedure in office, in the hospitals, in the medical centers, in the regional centers, depending on what region you're in, so that you can call people and ask questions. The more experts that are educated on this, the more you can have these questions answered, and people feel safer using it when you can answer their questions. Families do, patients do, and that's a really great long-term goal that we have in terms of stigma mitigation, both in Guyana and abroad. Talking about 4-stage counseling first, there's a couple studies done out of different countries, and what they found is that you really have to break up the discussion of what ECT is and how it's going to be used into 4 separate kind of meetings and interactions. This is not unlike a lot of other interactions you have when you're discussing with a patient what's going to be happening. But essentially, it's broken up into 4 sections. The first is introduction, talking with the patient about what they're looking for, building their confidence about their treatment, they're going to be okay, reassuring them, and understanding their history to make sure that you understand what's going on with them. The next is assessing their belief about whether they can do it, whether they can handle these things, whether they're going to judge themselves, and whether they're discriminating against themselves, whether they feel like they're not going to make it or they're feeling very unhappy, and kind of assessing where they are so you know where to get them and how to get them to a good point. The next step, these are all done separate days, hopefully, is assessing their compliance with treatment. How often do they want to come to these sessions? Can they come to these sessions? Do they have a car to get around? Do you have to take the bus? Are they walking from Berbice to Starbuck Market? How are they getting here? You know, promoting healthy behaviors and moving from results-based thinking, I'm not seeing an effect, to more performance-based thinking. This will be working for me in 14 in 10 sessions, or I think this will be helpful for my energy levels in 10 sessions. And the last is training on self-care, helping them understand how to keep their healthy behaviors going and encouraging them to talk about their disease, their treatment, how they feel about it over time. And these 4 interventions, these 4 counseling stages can really help mitigate stigma for the patient and their families. The next is kind of a reinforcing method, and that's talking about how to show positive examples of this to not just the patients, but their families as well. A couple of things that were looked at was that actually allowing the families into the room, like you saw in that video with that patient, the family into the room so they can see what's happening. This is not a secret. This is not something that's hidden. It's not something that we're scared of as treating, hopefully me as a treating psychiatrist in the future, but as psychiatrists in the future, this is something that we're proud of. It's a technique that is very, very effective. And in certain cases, appropriate for the family to come in and see what's going on so they can see their family member is safe, is not hurt, and is comfortable. And in doing so, you can help break down stigma. That may be scary because you may not want to be in the room, but by allowing them in the room and saying, hey, do you want to come and see what's going on with your family member? You can really break down that stigma. Similarly, there was a couple studies done that found that by trying to explain some of these mental disorders in a neurobiologic way, in terms of saying, this is something they're genetic or born with, and something that we can't necessarily change because it's a part of their brain chemistry, even if that may or may not be true in pieces, it's had the effect of kind of othering some of these people in society. So not to say that we should move away from these explanations, but de-emphasizing them as the only explanation for what's going on could be helpful in reducing stigma. So the key takeaway is, of course, this de-emphasis, talking about the procedure more, and letting family be a part of it. And finally, stigma mitigation. This is the last intervention that we found has been successful. And what this really means is understanding how patients see themselves as patients of electroconvulsive therapy, how families see electroconvulsive therapy, and talking with them about what it means for them, how long it's going to take, what the procedure is going to be, and how they feel about all of that. And really getting them to understand and accept that this is what's happening, and it can be a really big help. It's close to performance-based thinking and kind of thinking about how this is going to improve over time, but it's really a focused effort to get them to improve. And it's something that we see time and time again in these studies, that with that proper counseling about what the public's perspective is and how we can move that slowly and bit by bit, you see major improvements in reducing stigma in those populations. So hopefully, in doing all 3 of these things, you can see widespread changes in the stigma across populations, across regions, across countries, and across continents. And that's really what we're aiming for here. These three things are the things that are really focused on in terms of stigma reduction, and they've really been proven to be the most effective. And so these are the ones I wanted to focus on for you today. And their use in Guyana are actually very, very realistic. Many of these things can be discussed by training providers on ECT. We'll talk more about ECT shortly after this session. They get to know and understand what it does and how it works. And patients will really feel more comfortable with the technology and with the treatment process. And we're excited to do that. I'm excited to learn more about it from my colleagues in ECT. And I'm excited to answer any questions that come up from you in the audience right now, to the best of my abilities as a fourth-year medical student. And I just want to say thank you. Thank you for having me. Thank you for sharing this time with me. And special thanks to Dr. Lauren Hanna and Dr. Timothy Kreider, who were absolutely instrumental in helping me get this project up and running, getting me involved in this exercise, and helping me come back to Guyana virtually and share this with you all. So thank you so much. I'm happy to take any questions briefly, and I appreciate it. Thank you again.
Let me introduce and let me mispronounce Dr. Georgios Petridis. Is that right? And so,
Yeah.
Sohag Sanghami.
You got it right at the first attempt.
Wonderful. And the two of them co-direct ECT services at Zucker Hillside Hospital. They've expanded the services there tremendously, and especially during COVID. They have done a wonderful job of making those services available to members of the community, and expanded that program. They also co-directed. Not only have they done the actual work, they've done dissemination, and they have co-directed a 5-day certificate course, which I've just read about and I'm going to sign up for. And it's the only course in the USA offering AMA credit. So it's in other words, a validated training program, which is fast becoming the standard. Dr. Petridis is also an organizing member of the Committee for the Creation of the World Federation of ECT Societies and the Task Force for ECT Practice Guidelines of the World Federation Societies for Biological Psychiatry, which is becoming redundant because all of psychiatry is becoming biological, but we used to think of them as a subpart of psychiatry. And he's also president of the executive board of the International Society for ECT and Neurostimulation. So Dr. Petridis and Dr. Sanghami are two of the best people in the world to be giving a talk on ECT. And we really feel very fortunate that we are going to get this learning from such world experts.
Thank you, Dr. Amsel, for such kind introduction. And thank you, Dr. Martin, for your talk. So this, Dr. Amsel in the introduction mentioned that he hears this question, and we did not share these slides with him beforehand. And that's our title, ECT, are we still doing it? He mentioned physicians also ask this thing, that are we still doing ECT? And what I'm going to do is I'm going to go over some of the points which Dr. Martin earlier mentioned. So we'll go through that. And I'm going to show some videos as well. Now let's see if my mouse is working. Okay. I don't have any conflicts of interest. Part of my salary is supported by a grant from National Institute of Aging. Our goal is to familiarize everyone with history and current practice of ECT, discuss risk and benefits, and brief overview of mechanism of action. This is the public belief. This is what people think when they talk about ECT, because this is how it is portrayed in media. And Dr. Martin already showed a video where this is how it is actually being done. It is not a torture. It is like any other medical procedure. I'm going to present a video, two cases, and these are the cases of actual patients who had psychotic illnesses and psychotic symptoms. So you are going to hear some screams and loud noises. these patients have given us permission. So they were treated with ECT, they got better, and they gave us permission to use those videos which were taken by the family members. But please do not record this video. ECT was discontinued. Still pause the recording. In 1940, the first ECT was done in United States. And the introduction of general anesthesia was in 1958. Between that period, ECT was the most effective treatment for many psychiatric conditions. And one treatment itself does not give too much of response. It's usually a series of treatments. So patients usually return for treatments. Patient did come back for the treatment. And one question is, why do we need anesthesia? So just to understand, when we were doing ECT without anesthesia, when you do the stimulus, that stimulus produces a strong contraction for about a few seconds. It's literally a few seconds. And during those few seconds, the current is being delivered in small pulses. During that contraction is very strong, and that's why patients used to get sometimes spinal injuries or joint hyperextension and joint dislocation. To prevent that, they were administering succinylcholine, which is a muscle relaxant. Succinylcholine as a muscle relaxant cannot be administered when patient is awake, because it also paralyzes respiratory muscles, and you cannot breathe on your own. So that's why it has to be administered under anesthesia. It's mainly that period of 4 seconds. The seizures itself are clonic in nature. So there's a contraction, relaxation. That does not produce any injury. Before anesthesia, when they had to do that, to prevent that tonic contraction, you would need to hold the patient so that they don't hyperextend themselves, they don't go all the way backwards, and they don't sustain injury. Now, when all your muscles are contracting together, if your respiratory muscles are also contracting at that time, the air can come out against a closed vocal cord or closed voice box. And at that time, it may come out with an ah kind of sound. So for a bystander, 4 people are holding the patient, and there is a contraction happening, and you are hearing this ah sound. Patient is not aware. You cannot be physiologically, it's not possible that you can be aware when you are having a generalized tonic-clonic seizure. But for a bystander, that used to give a bad view, and it would look like barbaric, and that gave ECT a bad reputation around that time. From 1960 to 70s, there was decreased use of ECT because more medications were invented, more medications became available. Initially, the impression was that medications are going to solve all the problems. There was also an anti-psychiatry movement, and in between part was providers tried to use ECT for illnesses where it did not work. And then, as Dr. Martin mentioned, people tried to take it beyond the medical therapeutic reasons and try to use it for all other things. In 1978, American Psychiatric Association produced a task force report, which was again revised in 1990 and 2000. There have been many technical improvements, the pulse width and placements. So in older machines, if you see on your left, the current was sine wave current, and they changed the current to brief pulse. I cannot use my mouse to pointer, but you see the brief pulse, some amount of that current was eliminated. So in modern ECT machines, even if I'm pressing the button for 4 seconds, even at maximum capacity, the actual time for which the charge is being delivered is about half a second. So those half second is split over 4 seconds. And that's the treatment. After that, there is a conversion or seizure, which is from 30 seconds to about 3 minutes maximum. This is an article from 1941. This is the place where I worked at Zucker Hillside, the older building. But in 1941, at our hospital, ECT was introduced. And it was at that time, New York Times mentioned the hospital has pioneered in the use of insulin and metrazole, and also in the electric shock treatment, which has proved useful in shortening the average stay of patients. In those days, the length of stay used to be 3 to 6 months. This is map of Long Island. We are located at Zucker Hillside Hospital. The hospitals listed are many of the Northwell hospitals and Northwell affiliates. So we have one of the largest ECT service. There are other hospitals that have ECT service within Northwell. There are other academic institutions in New York area. You have Columbia University, Mount Sinai, NYU, Stony Brook. They all provide ECT services. And if despite all these providers, I can just share our volume, how many patients, how many treatments we are performing. Oh, sorry. So this shows how many treatments we have been performing. Pre-COVID, we were doing 7,844 treatments. And this kind of, and we are not the only provider in the region, right? So this highlights how much of a need is there, despite the resources available in healthcare and in mental health field. There are going to be patients who need this treatment for depression, for treatment-resistant psychosis, and this exemplifies them. So what are the indications of ECT? APA task force defines that whenever there's a need for rapid definitive response because of the severity of a medical or psychiatric condition, including suicide risk, or when the risks of other treatments outweigh the risk of ECT, or there's a history of medication non-response or prior history of good response to ECT. Secondary uses is treatment resistance, intolerance to or adverse side effects, deterioration of patient's psychiatric or medical condition, creating a need for rapid definitive response. You saw the previous 2 videos, right? They tried a lot of medical treatments. Now, patients spend months waiting for improvement, and with ECT, within few treatments, there was a significant change. In the psychiatric world, we go by diagnosis. And so if you talk about diagnosis, ECT is very effective in all forms of major depressions, whether it's unipolar depression, bipolar depression, psychotic or non-psychotic, single episode or recurrent. It is even like comparing within these classifications, it is more effective in psychotic depression compared to non-psychotic depression. The response rate is 70 to 90%, and about 65 to 70% of the patients achieve remission with the course of ECT. It can be used in schizophrenia as well, but in schizophrenia, primarily, it is used as an augmentation of antipsychotic medication. So if someone has a non-response to antipsychotics, ECT can augment the efficacy of antipsychotic. In some cases, while we are awaiting for antipsychotics or patient is not able to take antipsychotic, ECT can be used as first line, but that would be usually for a brief period, like patient is suicidal, patient is having catatonia symptoms, or cannot take antipsychotics. Worldwide, there is a different trend, and this highlights the issue of stigma, right? In the United States, for schizophrenia, so amongst all the patients that are receiving ECT, what is the percentage of patients that receive it for schizophrenia? In the United States, it's less, but in some other countries, it's pretty high. Africa is 60 to 83%, Asia 60%. So you can see a difference. In India, when I practiced prior to coming to States, we used to use it a lot for schizophrenia, and stigma has a role in this. It almost highlights that in some countries, ECT is being used for the most visible or prominent symptoms or illness which has symptoms which are more visible to everyone around, and severe illnesses in that form, but not for things like depression, which is sometimes hidden from the community. Same thing in Europe, within countries, there's a different trend. It is very effective in mania as well. So bipolar disorder, mania, mixed features. And sometimes, rarely, there are case reports of it being effective in other conditions like treatment-resistant OCD. Again, there are case reports that are not large studies in these conditions, but once in a while it can be used. It works very well with Parkinson's disease as well, although now there are many good treatments available for Parkinson's. So it's rare that ECT is needed. But if a Parkinson's patient has depression, the need for ECT may bump medications. It can be used for intractable seizure disorder or status epilepticus. Physiologic effects. So when we do the treatment, initially there is a decrease in heart rate, and then there is an increase in heart rate, which is very short-lived and very transient. I'm just going to, in the interest of time, I'm going to try to move forward. There's a transient increase in intraocular pressure as well as intracerebral pressure. Also transient increase in blood-brain barrier permeability. There is endocrine effect. Your hormonal axis gets affected, and there is some effects on the immune system as well. So what are the adverse effects? And the first thought that comes to mind is, am I going to die if I get this treatment, right? So we did a study, and the mortality rate is 2.1 deaths per 100,000 treatments. The rate of anesthetic sole mortality in surgery, meaning if you take all deaths that happen during surgery, and of that, how many of them can be attributed to anesthesia alone, not to the surgery, is 3.4 per 100,000. So mortality rate in ECT is significantly is much lesser compared to what is even for anesthesia in general surgery. Now, this number is also exaggerated number, because if, let's say, if someone had ECT today and tomorrow morning they're having breakfast and they throw up and they aspirate, that death would be counted in this because it happened within 24 hours of the treatment. So this number is actually an overestimation of the risk. Most common side, so temporarily, transiently, you can have heart rate changes and blood pressure changes, which are all benign. Rarely we can have prolonged seizure, which can be easily treated with oxygenation, anticonvulsants. Sometimes you can use ECT itself to break a prolonged seizure. It can be used as a treatment for treatment-resistant status epilepticus. The most common side effect is actually headache and nausea. Does not happen to everyone. If it happens, it can be easily treated with commonly used medications like ibuprofen and ondansetron for nausea. And then subsequent treatments, we would use those medications prophylactically to prevent those headache and nausea from happening. The most infamous side effect is the cognitive side effect, where people are concerned about the memory. And the cognitive side effects are called anterograde and retrograde amnesia, which means events immediately after the treatment and events immediately before the treatment are likely to be forgotten. So if someone is having a treatment Monday, Wednesday, Friday, events that happen on Tuesday are affected by Monday's treatment. Those memories get affected by Wednesday's treatment as well. And when you do not register the information, you may have difficulty recalling that information, right? So people may forget what they ate last time, last night. They may forget they had a phone call yesterday. And when you're doing the treatment for a series, the events that happened during that series, those memories may not come back because they were not registered properly. Now, whatever has happened in past is stored in different areas of the brain. People may have some difficulty accessing that information for a few months. And sometimes they may need reminders. So I had a patient who used to go to gym regularly. Because of depression, she stopped going to gym. While her depression got better, she wants to go back to gym. And she had difficulty finding the direction to the gym. As soon as someone drove her, all the old memories came back. She did not need a ride second time. So that can happen. But your ability to register and recall new information, that starts getting better within 2 weeks. And the older memories gradually come back. Some people may have some spottiness in memory that may persist, but most of the times it's not interfering with function. So our group has treated many physicians, lawyers, teachers, nurses who have gone back to the work and are functioning fine. And we have treated many relatives of physicians. I'm just going to go over. So there are no absolute contraindications for ECT. However, there are relative contraindications, right? Think of this. When you are doing the treatment, you are the physiological stress that it produces is literally similar to running on a treadmill for a couple of minutes. Your heart rate goes up for a few minutes, your blood pressure goes up for a few minutes, and then it comes down. So if someone had a recent heart attack, you won't let them run on the treadmill, so they cannot get ECT. Same thing if someone had a recent stroke, you need to allow some time for those things to resolve, but later on they can receive ECT. Patient had if someone has a severe respiratory condition like pulmonary hypertension, those things would be relative contraindication. So the $1 million question, so we have some time. Okay, so the $1 million question is, how does ECT work? And so it is one of the most effective treatment in psychiatry. Mechanisms of action are not well understood. That does not mean that we don't know what ECT does. We know a lot about what ECT does, but because it does so many things at the same time, and it does in so many different conditions, it's very difficult to pinpoint what exactly is responsible for this superior efficacy. Right, antidepressants can sometimes induce mania. ECT can treat depression, ECT can treat mania as well. When someone gets antipsychotic medications, one of the side effects of some antipsychotic medications is Parkinsonian symptoms, where they get rigidity and stiffness. ECT can treat Parkinsonian symptoms as well. So it works in a paradoxical manner. In catatonia, the most effective treatment is lorazepam, which is benzodiazepine. And ECT can treat catatonia very well. It works very well. So there it works like a benzodiazepine effect. So because it has wide range of action, it is difficult to pinpoint. But I'm going to go over what we know very, very briefly. Some people call it dirty treatment, not really that it's dirty to the brain, but because it's very difficult to study. And really, we have a limited biological understanding of all the psychiatric illnesses. As Dr. Martin had said, the older concept was that some certain illnesses cannot coexist together. So at that time, they thought schizophrenia and epilepsy cannot be together. And that's why seizure treatment works in psychosis, but that theory has been debunked. Initially, some people thought that there are some psychological theories that, hey, we are inducing fear, and that's why it works. Or patient is having convulsion, they're having some pelvic movements, so that has to do with some psychoanalytic concepts. But with anesthesia and muscle relaxant, those factors have been eliminated, and ECT still works. And it doesn't work by causing forgetfulness, because those memories come back, but the treatment effect still stays. And I'm going to go a little bit more about the brain damage thing, because people talk about brain damage. No one has found any evidence to support brain damage. And I'll tell you what I mean by that a little bit later. It affects multiple neurotransmitters at the same time. There is a hormonal axis, right? Our pituitary gland secretes most of the hormones, and they're connected to thyroid and other endocrine glands. And ECT normalizes a test which is called dexamethasone suppression test, which is a test of our hypothalamus pituitary axis. So ECT does work on that pathway as well. These are some of the other neurochemicals and hormones that it affects. Dr. Max Fink, who was mentor of my mentor, Dr. Petridis, he had proposed that at some point, someone is going to find a substance which is directly increased by ECT. No one has found it yet. The hypothesis of maybe medication and ECT are working together because the blood-brain barrier becomes more permeable, allowing more medication to go into the CSF or into the brain tissue. It has anti-convulsion property, so it makes changes in the brain wave patterns, and that may have a therapeutic effect. Neurotropic theories. Contrary to the belief that ECT may be causing brain damage or shrinkage, it actually increases the volume of hippocampus, and it actually leads to formation of new neuronal cells. Brain MRI studies have shown that there are regions of brain that show increased activity, and some of the circuits might be getting affected. So there are some networks which are in brain where certain parts of the brain are connected together, and there is an imbalance in that network, and that might be affected with ECT. These are all the studies which have been shown about potential mechanisms. So what about brain damage? No evidence of brain damage has been found in brain imaging, right? How would you assess for brain damage? One can do brain scans and see if there's a change in structure. No evidence of brain damage on brain scans. Then you can do functional MRI, which is scanning the brain while you are doing some functional cognitive tasks. There's no evidence of brain damage during those functional MRI. The other way of checking is if someone had received many ECTs, after when they die, if we do biopsy of their brain. So 89-year-old female who had received more than 1,000 documented ECTs plus unsubstantiated 800 ECTs. After her death, they donated her brain for biopsy, and they did not find any evidence of brain damage. 91-year-old female who had 91 ECT treatments did not find any evidence of brain damage. And 84-year-old male who died within 1 month of the last ECT treatment and had received 422 ECTs did not show any evidence of brain damage. And another way of assessing for brain damage is whenever there's a death of any cell, it produces certain substances which are called apoptotic markers or signs of apoptosis. Studies have tried to look for them. None of them have found any evidence of brain damage. So some people equate the memory side effect as brain damage, which is not really the same thing. And that also contributes to the stigma. So in summary, ECT is a safe and effective treatment for different psychiatric conditions. Early initiation of ECT may help prevent a protracted course, and stigma mitigation is crucial to increase access. ECT is very effective in suicidal patients. And also when it comes to depression, I want to make sure I convey a point. It's not only for treatment-resistant depression. It is for even for severe depression. You don't need to wait to prove that it is treatment resistant, right? When you try medication, it doesn't work for 4 weeks, then you try another 4. No, by that time, patient has significantly deteriorated. So someone is not eating, is psychosis or catatonia or suicidal. You don't need to wait for non-response. And when I showed some of the data saying someone had received 422 treatments, they are not all together. So in an acute course, when you're trying to treat the illness, the treatments have to be close together 2 to 3 times per week. Once someone is better, you start to space it out, and then they can receive what we call maintenance ECT or monthly maintenance ECT. Special thanks to the patients for permission to share those videos and our great ECT team at this and hospital. So I welcome any questions. I wasn't able to see the Zoom questions, so I do not know what are the questions posted on the Zoom chat.
I'm not seeing anything on the Zoom chat, but I want to open the room up. We have a few minutes for questions, so please raise your hand, or if you have difficulty with that technique, just jump in. It's okay, and throw out a question.
There are 2 questions on the chat. It says, is ECT effective for adolescents experiencing depression? And did you say across all populations?
Yes, so ECT is effective in adolescents. Actually, ECT has been used in adolescents since 1942. And at that time, Margaret Mahler was actually the chairman at Bellevue Hospital. And around that time, in 1942 onwards, ECT is being used in adolescents. We have treated many adolescents. Obviously, risk versus benefit discussion needs to happen. Parents have to consent for the treatment, and there are different state regulations. So in the United States, certain places, certain states would require 2 child and adolescent psychiatrists to agree before going for ECT. But if, as far as the efficacy is the same. Actually the cognitive side effects are less in adolescents compared to older individuals. So they have less memory side effects, and it doesn't have not been shown to affect any academic performance or anything like that.
Thank you. And then there's another question from Priscilla, I believe. What is the cost for ECT therapy? I'm not sure if that's for the patient or for the provider, but I guess.
Yeah, so that's an interesting question, and it would all depend, because my understanding is in this meeting there are people from different countries present, right? So it all depends on what is the cost of human resources and space in your country. That's the main driver. When it comes to United States, there are only 2 manufacturers that make this machine. Once they sell the machine, we don't buy another machine for 10, 20 years easily. So that's the initial investment in the space and the machine. The supplies, they have to be usual wear and tear. So some of the supplies needs to be replaced, but actual cost is not very high. It's more the space, anesthesia, availability of anesthesiologists, nursing staff, psychiatrists. Those are the factors that drive the cost, and that's going to vary from region to region, country to country. Dr. Hannah has a question here in the audience.
Yes, hi, thank you so much for the excellent presentation, Dr. Sanghami. There was the question earlier about special populations for adolescents. I was wondering if you could speak on like safety and efficacy and kind of predominance of use of ECT for other special populations, like for example, maybe pregnant women and the elderly.
Sure. So obviously we have ECT can be used in adolescents. Sometimes patients with autism who have repetitive self-injurious behavior, where they are doing it, it's a purposeless movement. And those patients, it's a variant of catatonia. and they respond very well to ECT. Dr. Lee Vachtel at Kennedy Krieger, which is part of Johns Hopkins, has treated many patients. We have treated few patients with that condition. As far as pregnancy, it is a very safe treatment, especially in the first trimester, when patients are concerned about teratogenic effects of psychiatric medications, which again have not been well established. But if the patient is very concerned, in first trimester, it's a very safe treatment. In second and third trimester, those patients are considered full stomach. So from anesthesia point of view, they would require intubation. So if someone has to be treated once a month or for maintenance, that's okay. But if they are requiring multiple treatments, you have to take into account the risk for intubation, because you don't want them to aspirate during the treatment. So multiple intubations can be something that's difficult to tolerate and has its own risk. But it is a very safe treatment in pregnancy. Sorry, go ahead.
Yeah, no, it's Dr. Amsel here. I wonder if you speak to, there's a real irony as I see it in the patterns of stigmatization of ECT, that not only is it generally stigmatized, but I believe that it actually, there's a sense that it is additionally stigmatized in minority and traditional minority groups and in the poor, and this sense that, oh, this is the treatment that people use on minorities and the poor. And actually, paradoxically, those are communities in which if there was a greater acceptance of ECT, we could actually reduce disparities in depression treatment. Do you understand my point?
Yes, and I agree with you. And that's a big paradox, actually. So historically, as I'm speaking about even Long Island Jewish Medical Center, where I'm talking about in 50s, there was a period when ECT was being offered to the rich and wealthy people, and
that's right.
And it was not offered to the rich and wealthy. And subsequently, now with insurance and it is available to everyone, but because of this notion of it being used as a torture or not having evidence or punishment and all those things, people tend to stay away from it, and acceptance is low. But there are some articles on that. I don't have the data about that, but I know there are some articles about those disparities.
Right, and so it seems to me that there might be a need for particularly targeted destigmatization, programs and dissemination, right, among minority groups, where it is seen almost as experimental, and it has for good historical reasons, it has a real negative aura about it.
Yeah, and also there's an issue about access. I mean, a couple of areas that I am familiar with, there's no ECT service in those areas where those are the neighborhoods that are poor and economically and socially disadvantaged position, but there's not a good access.
Terrific. Thank you so much. So I'd like us all to thank with virtual claps and cheers, thank our speakers for, and I've been familiar with ECT for many years and with this, but I thought this was, I learned a lot of new things. This was a wonderful presentations, both about the nature of ECT and the nature of its potential. When we talk about Guyana and well-being, and when we talk about increasing population well-being, there's a real role for ECT. I think the take-home message here, there's a real role for it. And one of the steps that will be necessary to achieve that is to make sure that we properly communicate and destigmatize it and communicate its usefulness. So I want to again thank our panel, and I look forward to collaborating and working with all of you in the future. So with that, I think we're going to officially end this talk. Thank you so much.
Thank you so much.
Thank you.
So Dr. Hannah had asked about special population, and one part I forgot to mention was about geriatric population. So it works very well in geriatric depression. There are studies that have shown its superior efficacy in geriatric depression. In addition, many of our old age patients, geriatric patients, they cannot tolerate many medications or because of the side effects, or they are on so many medications because of different medical conditions that there are drug interactions. And ECT works very well in geriatric depression. Now, the practice is different in different countries. When I used to do ECT in India, we did not do that many geriatric patients because our anesthesia setup wasn't equipped to handle that. When I came to US, we are treating way more, most of our patients are geriatric patients. And we have what we call as 90s club, where we have patients in their 90s who are receiving regularly monthly ECT.
What about dementia? Patients with dementia.
So patients with dementia, ECT does not treat the dementia itself, but when many patients with dementia get into a stage of this agitation, which is like constant agitation, and ECT works very well in that condition. Now, there are open label studies at major medical centers, including ours, as well as at Harvard, and Emory University, that have shown a series of patients where ECT was able to reduce that agitation in dementia significantly. We are currently conducting a study which has been funded by NIA to study specifically ECT's efficacy in treating agitation secondary to dementia.
What's the question?
Any other question from the audience?
I can't really, so I would like to know what. I can't really.
Okay, so the question is, someone who entered late who wants to know what is ECT. ECT is using electricity to stimulate the brain for a few seconds to treat different psychiatric conditions. And when we stimulate the brain, it produces a small controlled seizure. So the word E, the letter E stands for electricity, C stands for convulsive, and T is therapy. So ECT, electroconvulsive therapy. It is done under anesthesia. It is a controlled seizure, usually stops within a minute, and it's a very safe treatment.
Thank you.
The question was ECT in children and adolescents. Yes, when we have treated adolescents with depression, and we have also for depression and psychosis. So it is a safe treatment in adolescents. Obviously, you need to make sure it is the indicated treatments. You want to make sure your diagnosis is correct, and because people are concerned about are extra protective of kids, sometimes different states would recommend for two child and adolescent psychiatrists to agree about the need for ECT, but that is mainly coming from because of this fear of the memory side effect part. In our experience, actually, adolescents get less memory side effects compared to adults. So it is a very safe treatment. We talk about the psychiatric conditions. We have treated a condition of status epilepticus, where someone was having seizure due to medical condition, which was not stopping. And we have treated even a 3-year-old for that indication. Those are rare, extreme rare case reports, where someone has status epilepticus or autoimmune encephalitis, and they are in a state where ECT is indicated.
Doesn't apply in Indiana. Do you have
So right now, Guyana doesn't have ECT, but there are talks that GPHC would like to restart it. And we are going to try our best to help collaborate and in restarting. Guyana has a need, like you see the incidence of suicide, depression, and ECT works very well in those conditions. So there's definitely a need, but so hopefully GPSC will be able to start it soon.